so now we have a patient. Let's just say he's high school again. Had a game on Friday night. Football player. He is an all-state running back. Um, Non-contact injury. He was carrying the ball. He went to make a cut off of his right leg. He felt something happen. Didn't feel good. Took him to the ground. They obviously iced it. He didn't go back in the game. That was Friday. So Saturday, he's up. He's walking on it. It's feeling okay, but it's definitely swollen. And he's just not sure. They can't get into an orthopedic that fast. So they came in to see me. So same type of deal. I want to know as best as I can, does he have any history of knee problems on this leg or the other one? How did it happen? Was it contact, not contact? Could he walk on it right away? Did he take a hit? Could there be a bone fracture, anything like that? Does he remember which way his knee went? Obviously assess that knee on where it's swelling. Somebody like this who just had the injury, I'm not going to have him up. I'm not going to check anything because he's pretty fresh. So we're not obviously going to run him. We're not going to jump him. We're not going to squat him. None of that. I'm going to have him go ahead and lay on his back over here. So the first thing I would always do, and depending on how he can even lay here comfortably, he might be laying here and is having a really hard time wanting that knee to go straight. He's really swollen. Maybe he's not swollen at all and he can just lay there. But I'm always just going to feel, I'm going to push on some different spots. I'm going to feel the medial joint line, lateral joint line, around the kneecap. I'm going to feel on the back side where the hamstrings come in, where the calf comes in. I want to make sure I know, was it a kneecap that moved or was it deeper? I'll be picking that up as I'm talking to him. But I'm also going to come in here and just wiggle that kneecap a little bit, in and out. Make sure that doesn't bother him. If it's structurally inside the knee, that wouldn't hurt necessarily. If he dislocated or subluxed his kneecap, he might feel a little something, and I might feel that it's moving a little too much than it should be. The next thing I'm going to do is I always want to assess his range of motion. So the knee only goes really two ways. It bends and it straightens. So we want to see just how straight this knee goes. I'm always going to put pressure down here and give him a little lift. I know he's at least at a 0 degrees there. Always going to assess that other one to get an idea of where should this knee be in relation to his other. We still don't know what's wrong with him yet. He says, ow, a little bit there. That's not real comfortable, but we can get him there. Then I want to see how far he can bend. And usually with an acute injury like that, he's probably going to sit somewhere right in here and he's going to go, ow, I don't like that. My knee feels like it's going to explode. And I'm obviously feeling here as we go. He comes down. Then I'm going to go into some special tests. The first one I always like to do is get an idea of that ACL right away. So I'm just going to do what we call Lockman's. Pretty subtle. You won't really see it on camera, but I'm just going to give an anterior translation there through the tibia and see if I get an end feel and how snug that is. Then I'm going to go right into a valgus stress test here, where I'm just kind of putting a stress through the outer side. I'm assessing the MCL. The Lockman's was checking the ACL. But I want to see, is that painful or how much does that gap? Just depends on where he's complaining of pain. I might come in here and come over to the either way here with just what we call an relax. Hammy's kicked in there. Just an anterior drawer, where I'm just pulling again, checking ACL, and I might do a posterior drawer, checking PCL. And all I'm feeling for there is how much that's moving and if I'm getting an end point. Never hurts to get a feel for that other knee, because everybody's a little different. You might feel like it's really moving, but then you come over here and it's just as loose. Really hit the Lockmans on both sides there too, just to make sure. Everybody's different. Now let's say he told me that he had an audible pop. He heard it go. Um, and this guy right here, this Lockmans, was positive. I didn't get an end feel. There was a lot of translation there. At that point, I'm going to give him some exercises to do. I'm already suspecting that the ACL is torn. And if that's the case, we're getting him into an ortho to take a look. Probably going to have to MRI this and see what direction we want to go there. Let's say he gets the MRI, it's a positive for an ACL tear. Odds are we're probably heading the direction of surgery there. Say it wasn't, and we're positive on the MCL tear. In that case, depending on the severity of it, we might go to an ortho. We might just ride this out. MCLs will heal on their own unless it's just a massive tear. So it just depends on what we suspect there. Those are kind of the two big ones. Flip onto your stomach. If that's all checking out so far, everything just kind of hurts, but ligamentous wise, he doesn't feel too bad. We really should just assess that meniscus. We're going to do what's called a McMurray's and a dynamic McMurray's. So if he had a meniscus tear, if I come here and I go to bend him, he's more than likely not going to like it. He's going to say, ow, that hurts a lot. This side would go a long ways, okay? A McMurray's now, just to confirm what we're thinking, we're going to put force down on that knee, load that meniscus, and then I'm going to do some twisting on it. If he has a meniscus tear, this is probably going to hurt. If he's like, yeah, that kind of hurts, I can't really tell though, I'm going to go into a dynamic McMurray's. Now I'm going to put him down, rotate him. Doing okay, Joe? I'm going to hold that pressure down with the rotation, and then I'm going to drop this knee down into extension. And more times than not, this one will really clue us in. He will not like this at all. If that's the case, and he's positive on that one, we are going to an orthopedic for sure. The ACL or the meniscus, he's got to go in and get that MRI. Would be the smartest idea. Come around. Let's say he's just, that was all fine. Roll onto your back. We think maybe it's just a knee sprain. We didn't pick up on ACL, MCL, meniscus. Maybe he kind of tweaked this thing. Maybe it was just a hyperextension injury, and we're just swollen, but ligamentous wise, we're good to go. Then we're going to start him on just some real basic stuff. We don't want the quad to shut down. He's obviously gonna ice it and all that. He's not gonna play right out of the gates. So I'm just gonna give him what I call a quad set. Just squeeze that quad down. He's just gonna make that muscle there, hold it for 5 seconds. He's gonna repeat that for a set of 10. Then we would move to just a straight leg raise. So he's gonna hit that quad set, lock that in, don't let that move, go into a straight leg raise. We're gonna hammer that guy. You do a set of 10 there to keep the quad awake. I'm also gonna give him, remember he only went to about 80 degrees of knee flexion. And we need to get that moving. So I am gonna promote bending of his knee. He's gonna be in quite a bit of pain, so he's gotta use his hands to help him here. And he's gonna do a heel slide. So the heel stays down, and he's just working that knee. I'm cueing him to go up to where it hurts, doesn't like it, hold it there for about a second or two, and then come all the way back down straight. And he's gonna repeat that 10 times, trying to get this knee motion back. Even if we're suspecting an ACL tear, I would still be giving him this because we need motion back, we need swelling down as fast as we can to go into surgery. Meniscus tear, I'm probably not going to go here because as that knee bends, we're putting more and more stress on the meniscus. Remember, he's going to the ortho for that. But say it's nothing, those are kind of the basic ones that we're going to start with for the knee.